Perfect. So it's just about 2 o'clock now, so I'll kick off. Welcome everybody. Hello, welcome to this Human Factors webinar from the SHOT team. Just want to start with a bit of an apology if anybody's had any difficulties accessing the webinar today. Hopefully we've sorted all those communication issues out, but we'll hopefully improve for the next session. So today's webinar is going to be surrounding human factors principles, and a bit from the SHOT report chapter on human factors this year. It will be a 40-minute presentation followed by a question and answer session. And we're asking you to pop your questions in the Q&A box that you'll see at the bottom of your screen. And please refrain from using the chat box. That won't be monitored quite as closely. And if we use the Q&A box, everybody can then share and see what questions you've answered. You'll be muted for this session as well, because obviously we've got quite a few participants today. So that just helps keep the noise to the minimum. So our presentations today will be from Emma Milser. She's our PBM and haemovigilance practitioner specialist. Dr. Alison Watt, who's our human factors expert and our SHOT steering group member, expert in human factors. So nice to see you, Alison. Welcome back, previous SHOT team member. And Dr. Shruti Narayan, who's our medical director today. So once again, thank you everybody for attending the webinar. I'm going to pass over to Emma now and looking forward to hearing your questions later.
Thank you very much, Vicky. I'm just going to stop my video. So hopefully everybody can see the slides okay. So once again, I'd just like to take this opportunity to thank you all for joining us on this webinar, and also especially to thank you for your hard and selfless work during these challenging times on behalf of everyone at SHOT. And we're grateful to you, our transfusion community, for rising to the challenges these unprecedented times are presenting us with. So just to provide an outline for this presentation, we're going to discuss the fundamentals of human factors and their relevance to transfusion, to present the highlights from the human factors chapter in the 2019 annual SHOT report, and very importantly, outline the way forward in this sphere. So let us begin with an overview of the fundamentals of human factors. So what do we mean by human factors? Well, the Chartered Institute of Ergonomics and Human Factors give us a nice definition, and they define human factors as the scientific discipline concerned with the understanding of interactions among humans and other elements of a system. And we must be mindful that it's just back to the previous slide, Shruti. It's a singular phrase, so it's human factors is, not human factors are. And it's an established scientific discipline used in many safety critical industries such as airlines and oil. And as we know, every day in the NHS, tens of thousands of patients are treated safely by dedicated healthcare professionals who are motivated to provide high quality care. And for the vast majority of these patients, the treatment they receive alleviates or improves their symptoms. However, an unacceptable number of patients are harmed as a result of their treatment and as a consequence of admission to hospital, meaning we must look at systems. So human factors does not just mean focusing on humans as a single entity. And human factors encompasses all of the factors that can influence the behaviour and performance of human beings within a system. It allows us to understand how people perform under different circumstances and why errors happen. And NHS England further described this as enhancing clinical performance through an understanding of the effects of teamwork, tasks, equipment, workspace, culture and organisation on human behaviour and abilities and application of that knowledge in clinical settings. So within transfusion, you may recognise some familiar tasks here on this slide. You can move on to the next one, please, now, Shruti. And again, human factors should not be mistaken for only being about factors related to the human themselves, as there are multiple environments, types of equipment and technology and critical steps involved in the transfusion process. So understanding the importance of human factors and how its concepts can be applied by individuals and teams is fundamental to improving patient safety. As we can see on this slide, transfusion is a complex multi-step process involving members of several different professional groups. So collaboration and coordination among staff involved is vital in ensuring the right component is transfused to the right patient at the right time, and there's scope for potential error at every stage. And at every step demonstrated in the process mapped in this chart. For example, if an accidental error was to occur in taking the wrong pre-transfusion sample at the very beginning of the process, this can result in death of the patient at the blood administration stage. And this makes it vitally important to understand human factors principles and build robust systems, excuse me, throughout the chain. James Reason introduced this Swiss cheese model shown here, and what this demonstrates is that within any system there are many levels of defence. So within transfusion, for example, these may include checking blood components before administration, using a pre-transfusion checklist, or taking pre-transfusion blood samples. However, each level of defence has little holes, or latent conditions as they're sometimes known as, which are caused by poor design, decision-making, procedures, lack of training, resources or staffing levels and such like. And if these holes become aligned over successive levels of defence, they can create a window of opportunity for a patient safety incident to occur. And latent conditions also increase the likelihood that healthcare professionals will make active errors. And when a combination of latent conditions and active errors occur, this can cause all levels of defences to be breached, and a patient safety incident can occur. Next slide, please, Shruti. So to help mitigate these holes or latent conditions, it's important to apply human factors principles to all of these aspects. So designing policies and processes, instructions for work and equipment, training and providing a safety culture and environment, and also carrying out investigations when things do go wrong. Next slide, please. We often talk of the vein-to-vein process in transfusion, and it's important to recognise that human factors principles apply to all steps within this process, from the point of donation, the packaging and transport of components that occurs, the measures and steps taken within laboratories for testing, processing, correctly storing components, the delivery of the components to the point of patient need, and finally to the end point, which is transfusion to the recipient. So to move on, what were the human factors highlights from the 2019 annual SHOT report? Well, as we consistently reiterate, improving transfusion safety is at the heart of everything we do and underpins all haemovigilance activities. And in 2019, there were 2.3 million blood components issued in the UK. And it's important to note these key facts. So blood transfusions in the UK are generally safe. The risk of death from transfusion has been demonstrated to be around 1 in 135,705, and the risk of serious harm at 1 in 17,884 of components issued. And all of transfusion all the transfusion complications, the risk from transfusion transmitted infections is much lower than all of the others. We do have a good reporting culture in the UK, as you can see, with the number of reports increasing gradually year on year, with around 18 reports per 10,000 components issued. And in 2019, 4,248 reports were submitted to SHOT. So this slide demonstrates cumulative data for SHOT categories from 1996 to 2019, and we now have more than 20,000 reports which have been analysed under the various SHOT categories. I won't discuss everything on this slide, and it may be familiar to many of you, but I would like to draw your attention to the group here at the bottom, which refers to reports due to mistakes. And the important take-home point here is that these are preventable errors. So to move on to near misses continue to account for a large proportion of the events and reactions reported to SHOT. And near miss events do not cause harm, but if undetected, they do have the potential to do so, and potential system failures and hazards can be identified and corrected before harm or injury occurs to patients by investigating these near misses. Unfortunately, as this graph shows us, it's disappointing to see that errors do continue to constitute more than 80% of analysed reports year on year for the last few years. So what are the potential impacts of errors in transfusion? Well, the impact of errors can be quite variable, ranging from no effect at all to resulting in patient death. And to point out, however, there was a case in 2015 where the wrong unit was collected from a remote issue refrigerator, and an error was made when checking the patient ID against the blood. The error was not realised until after the full unit had been transfused. The patient unfortunately subsequently developed suspected cardiac tamponade and died some hours after active intervention. And this case unfortunately resulted in a nurse being convicted of unlawful killing by gross negligence. And this demonstrates the huge and potentially devastating consequences of such errors. We also know that adverse events can have a wider reaching impact. There is potential of severe distress to the family involved, the emotional and professional impact on the staff involved in the incident, a cultural impact on the department as a whole, and also reputational damage to the organisation. And it should be noted that where staff are highlighted as the sole cause of the error, this is likely to have a negative effect on healthcare organisations with no improvement in patient safety. You may be familiar with the Human Factors Investigation tool, and SHOT have used this since 2016. This asks staff to score 0 to 10 under each category as being key factors identified during incident investigation. And as you can see, these 4 categories are staff, environmental, organisational, and government and regulatory factors. And this has demonstrated continually that these common themes occur. So attribution bias, human factors, missed opportunities, training and support, and staff need to be trained in the basics of human factors and have access to human factors experts. Also, staff are encouraged to participate in a human factors based vein-to-vein audit, and more information can be obtained from the SHOT office or the National Comparative Office around this. So this particular slide is quite busy, but we encourage you to read the human factors chapter to find out more information. But some of the key points for me to highlight are that over a third of incidents, so 34%, were scored for a single contributory factor, and the vast majority of these, 95%, were given a score only for the individual staff member. Furthermore, over 4 years of the study, there's not been a major change in the distribution of scores given to the 4 human factors, and this can be shown in the figure at the bottom left of the slide, although the trend across the 3 years is to assign slightly less responsibility to the staff members, especially where educational material has been used. But this reminds us that incident investigations should be thorough, systematic, and identify system issues. Often we hear about the dirty dozen, a term you may be familiar with, and these are factors which contribute to errors in healthcare, and they encompass all of the factors shown. We do know that these are certainly compounded by staff shortages, so it's imperative that we have adequate staffing to ensure safe patient care. And we do recognise that adequate staffing can be problematic to calculate, and a simple staffing capacity template is available on the SHOT website. Also, capacity plans should be reviewed regularly and updated for any changes in workload or changing requirements. We must also be mindful of cognitive biases as sources of errors, and these can be thought of as cognitive shortcuts which are used to aid our decision making, and these may include assumption bias, information bias, conclusion bias, and these can lead to unconscious thoughts. More information about cognitive biases and especially how to mitigate these can be found on the SHOT Bite of cognitive biases on the website. So all of this leads us on to one of the main recommendations from the 2019 annual SHOT report. So if I can just draw your attention to our second recommendation, that holistic training of all staff in transfusion should occur, and clinical and laboratory staff should be trained in fundamentals of transfusion, human factors, cognitive biases, investigating incidents, and safety principles. And I'm now going to hand you over to Shruti, who will elaborate on some more of this and how this can be achieved.
Thanks very much, Emma, for that excellent overview. And I think what we are now doing is, having had the overview of the human factors principles. The question now is, how do we embed? And some of these Emma has already alluded to. What can we do to embed it into practice? What can we do to make a difference to the transfusion safety? So just as a reminder from the previous slide, we have identified that the human factors principles are vital in every part of the patient care. Now, the key factors that we need to consider, it has to be a multi-pronged approach. There is no one single fix for this. And what we need to do is start from the very beginning, how we design our systems. How do we actually provide for the resources? What are the policies and procedures that we have? How do we train and educate our staff? As well as how do we actually practice in our day-to-day clinical and laboratory practice? And when things go wrong, how do we actually investigate them? What is the prevalent safety culture in the organization? And what is actually the leadership that is available? And we see that if there is a error in any of these, or if there is something lacking in any of these components, then patient safety can be actually compromised. So this is coming back to the design. So the very fundamental level, we need to design for safety. So it has to be a proactive, a predictive approach that we need to see. And this is one example where we have seen errors have been made in the theater with the point of care testing. So these two machines are actually then testing two different things. One a hemoglobin as a near patient testing, and another one is a glucose with totally different units, but they look alike. And therefore the chance of committing an error in a hyperdynamic situation is actually going to be high. So that is a question that we need to ask in our dynamic environments. Have we made it easy for staff to follow the right procedure and more difficult to deviate from the procedure? And that should be the mantra that is actually recurring. Can we design for safety? What more can be done to allow people to actually do the right thing easier? Now, when we come to policies and practices, this was in our 2018 report as well, as to how we want to actually make it much more simple. And again, the same thing, make it easy for people to actually follow the process. So here we see they need to be clear. They need to be logical. They need to make sense. They need to be easy to follow. And people who are following this should understand what the reason that they are doing it. It should be workable, it should be simple, and it should be actually relevant. And it is actually through these steps that we can ensure that if the policies and procedures are in place, you're actually then ensuring that people are more compliant and there would be less chances for deviations. Now, Emma has already alluded into this earlier. What we need to realize is for a high quality, safe patient care, everything should be in place for the safety aspects to actually work for the patient. Now, if there is, this is a completely interlinked system, and this is based on even the WHO building blocks framework. But we know that if you are having staffing issues, if you don't have the right resources or the right equipment, then you're already starting off on a poor keel. So you can see this, if there is any breakage in the system, it is actually going to affect the patient care. So what have we actually covered so far? We have said we need to design for safety. We need to have adequate resources. We need to have simple policies and procedures. And obviously, we also need to train and educate our staff. Now, we know historically, so when BSQR, that's the Blood Safety Quality Regulation, which mandated competency assessments for everybody involved in transfusion, came out in 2005. This is just a simple example, and there were several other factors that has led to the reduction in the ABO incompatible transfusions. So we all agree that education and training is vital, but the vital questions that we need to ask is how we are educating adequate enough? Are we actually training from very early on, start in the medical schools, nursing schools, to embed the principles of the patient safety, the human factors principles? And when we are training people, it is actually not just the what and how that they need to do the work, but also why. And if they understand the rationale, they are more amenable to follow the process and understand the impact of any deviation. And it's also important to keep that training not as a one-time event, but is actually a recurring one. We need to understand that competency assessments are actually a one-time check in the process. So when we did an audit a couple of years ago, a deep dive into some of the reports, we then realized that most of the errors, you can see here more than 70 to 80% of the errors were actually done by people and staff who are actually then well-meaning, but have also been trained and deemed competent. So I think where we are looking at is training needs to be a continuing process. It should be actually involving the right people. Interprofessional training is actually, would be beneficial. You're training as a team because you're working together as a team. You need to be able to use technology, keep it engaging, keep it immersive, and also explain the rationale for the procedure. The other thing that has come out from our report is, as we have already alluded, it is not just training staff in technical training, the transfusion aspects, but it's also important that they need to understand the holistic patient care. So they need to be able to understand the patient safety training. They need to be able to collaborate and as well as communicate with each other, because that is the main theme that comes out in most of our short reports, that poor communication and poor functioning between the teams and coordination is actually the result for the resulting in errors. So we need that leadership training, quality improvement training, and awareness of the cognitive biases, because in some of the studies, up to 20% of the errors could be actually due to cognitive bias. So can we train against that, address the knowledge deficits, but also actually mitigate the cognitive bias by metacognition? So therefore, that is the fundamental basis for our recommendation this year, is that all staff should receive holistic training. So we have the right system. We have also put in the right policies and procedures, ensured adequate resources, and we have trained our staff. The other aspect to consider is, how are we investigating the incidents? Now, as Emma has alluded to the HFIT tool, one thing that is emerging is, people may be investigating the incidents, but are we optimally learning from these investigations? And are we again asking the right questions during these investigations? Now, it is imperative that we need to ask the how, why, what, where, when, before we ask who. So it is actually more important to address the underlying factors that resulted in this deviation. Now, what the figure behind you is actually showing is what is the range of the corrective actions and preventative actions. All of them have a place, but we need to remember that if just by adding another extra step, another checklist, you're not actually building robust system for the long term. So it is more by automation, by computerization, by forcing a function, so that if you're actually saying the LIMS system cannot issue any ABO incompatible unless there is an active override with the reasoning given it's a clinical decision. So I think it is those forcing functions that you're actually putting into the system, which actually allows people to actually make it more difficult to actually do the wrong thing. So that is the essential principle that we need to actually incorporate. And on that note, I will hand over to Alison, who would then be discussing some bit from her PhD work, as well as how we work in our day-to-day practices and what are the influences. Over to you, Alison.
Sorry, rookie error, forgot to unmute. So this is a slide that shows the different kinds of work. There's quite a common usage of work as done compared to work as imagined. Work as imagined is what the managers think you can manage, and work as done is the day-to-day reality of doing things with poor resources, lack of staff, etc., etc. And this diagram also highlights a couple of other things. Work as prescribed, which again would be, this is how you will do the work, rather than looking at the reality of how work can be done in a situation. And also work as disclosed, which covers a little bit of how people pretend they may do something one way, possibly more like the policies, whereas in reality, we don't do it like that round here. Can we go on to the next slide, Shruti? This is work that's incomplete at the moment. So the same person that designed that earlier slide, Stephen Shorrock, who's a very good human factors expert, he's currently doing a blog on each of these aspects of different types of work as done. He's only got as far as the work as disclosed. So he's done work as imagined, work as prescribed, and work as disclosed, which were all on the previous slide. But have a look out on that link for him doing a blog on all of the others. And you can imagine the difference, some of these. So again, anyone that's done simulations will know that what you do in a simulation is nothing like real life. Go on to the next one, Shruti. This requires you to think about plugging the gap for all of these different types, whether it's 4 varieties of human work or the very many that Stephen's working on at the moment. And the need to shed a light about how we can bridge the gap and design things that are user-centered and centered on what the human does in the system. So what I did in my PhD was looking into the process resilience. So you've seen this little diagram before. What we did was walk through the transfusion process in 4 different hospitals, covering all of those 9 different steps, and asked a very simple question, which is, what's the biggest problem you have when you're doing this, whatever it is that person was doing? And all of the people questioned gave at least one example, and several gave more than one. So we had nearly 100 examples of where problems had been overcome by an adaptation. And the problem with adaptations is that if you're not solving the underlying issue, which we can see on the next slide, Shruti, this slide shows that the adaptations are triggered by various aspects of the system. So if you look at tools, IT, the task, the process, and more importantly, the people, those are what are causing the problems. But when you look at the right-hand block, you can see that the solutions tend to be around the processes and the task. And that's because these are the things that people on the ground can change quite easily. It's hard to say our IT system's rubbish or we need more staff. So they change a process to try and overcome the problem that they're having. And so I looked at this in the next slide and looked at 3 different sorts of questions. So if you look at the adaptations that people make, and this is something that's actually quite applicable. You can ask this in any audit. You ask that very simple question. It's like magic, people just talk. And then if you look at what they tell you they are doing, so this is the real work as done, which is not the work as imagined. And then you say, is the adaptation in the same aspect as the trigger? So in other words, are they solving the underlying problem? The other question I asked was about whether the managers and their colleagues were supportive of what they'd done. And then also looking at how permanent is the adaptation. Is this just a workaround? Is this just today because one of the staff is off? Is it just this week? Is it something because you're waiting for a more permanent solution? And then if you assess those, you can see whether you can decide whether it suggests this is going to be a successful adaptation, or it might be an unsuccessful one that could lead to a major problem somewhere further down the line. If we look at the next slide, I did a couple of worked examples on this. So this I know is quite a busy slide, but we'll just go through it fairly slowly. So if you concentrate on the pink boxes first, the first example is a process that was causing problems. So these are real cases from the research I was doing. And the patients that were having regular exchange transfusions for things like sickle cell diseases wanted to have them at more convenient times of the day, after work, after school, that sort of thing. So they amended the process in this hospital to improve that service to the patients. And if you think about it, that adaptation's in the same aspect. So the process was causing a problem and they amended the process. All of the staff were very supportive of it. The managers were supportive, the patients were supportive, and it was a permanent change. They'd made a proactive quality improvement. And the expert assessor, who in this case, of course, was me, it was quite easy to score that 5 out of 5 as this is likely to be successful. And then if you just follow the arrows and the pink box up to the top, the key thing there is to amend the standard process. So go back to the work as imagined and change the process so that the future changes are recognised and nobody forgets that there's been a change to this process. If we compare that with the light blue boxes underneath, and that was a second example where the problem was the tools, the IT, and the process had to be adapted to include generic logins for a computer because it timed out too quickly and would often lock the computer and they couldn't find the person that was logged into the computer and that computer became unusable. That's a very poor situation to get and a very bad way of getting around it. So they couldn't amend the actual underlying problem. So a process change had been made and this violation became an accepted form of practice. So you can see the adaptations in a completely different aspect. The supportiveness score, they had no supportiveness. They gave it as non-applicable because they hadn't told anyone. And clearly they're not going to tell management, they're not going to tell other wards that this is how they get round their problem. And the permanent status, this was clearly a temporary local workaround. The permanent fix would be to change the computer. And then obviously that was scored as a 1 out of 5 And that assessment shows that this is unlikely to be successful. And therefore, if you go down to the bottom for the feedback loop there, you need to be considering remedial action so that the staff don't feel compelled to violate an unworkable policy. So I hope those have shown you some ideas out of my PhD, and there was a link there so that you can go and have a look at the main thing. I'm going to pass you back to Shruti now.
Thanks, Alison. And I think that that is a great insight to the variations in our work in the day-to-day practices and how deviations and adaptability is actually a core part and understanding these. And I think that is where we need to actually work a lot more on. Now, all of us agree IT is integral to our transfusion practices vein to vein, and IT helps support and improve patient safety and transfusion safety. But one fundamental thing for us is actually that for IT to work well, they need to be configured correctly. These IT systems need to be used appropriately by staff, and they need to be actually interfaced. Now, we have been for several years including IT errors in transfusion as a chapter in the SHOT report. So please do go there, where we have actually elaborated on a lot more. And one of the key SHOT recommendations have been for the last couple of years is actually incorporate the electronic systems vein to vein, and they would be helping in improving the patient's safety. And we have seen where patient identification errors are also very common, then we can use these IT systems as a confirmatory step. And I've given the reference there to actually highlight the importance of the electronic systems. But equally, I think these also become another point where errors can be actually made. So this could be in several ways. If the process is actually not is being made difficult, that people are not following it, or there are flags which are actually keep on popping up, which are not easily overridden by the laboratory staff, or they are too complex, they're too multifaceted, or if there are no robust processes for the specific requirements to the laboratory to allow timely communication of the flags to the LIMS. So I think there are several instances where IT errors can be actually seen. And more recently, the IT working expert group members from SHOT brought out the SHOT Byte, which is again a short 2-page synopsis. And this shows the range of the IT errors that are actually seen in all these different categories. And you can see the biggest category here is the specific requirements not met category, where the errors occur. And the type of error that is actually often seen, as you can see, is the failure to use the flags or logic rules, or warning flags not being updated with time. So I think it is also important to understand, what are our blind spots, what are our weak areas, so that we can actually focus to improve and address and mitigate these errors and hopefully reduce the impact of these errors. So what we have been telling all along applies to IT as well, that even IT solutions that we are actually incorporating, should be simple, easy to use. They should not be increasing the cognitive load, and they should work with every system and procedures, and they should be compatible with the current equipment as well. And the staff need to be trained towards that. In addition, staff need to also be reducing the alert fatigue. So how do we actually do that? We need to have a system where you regularly review and reduce the redundant alerts. We need to make sure that all the alerts are contextual to be able to pick out the signal correctly to be actionable. And we should also ensure that there are adequate plans in place to appropriately escalate so that the correct members of the team are notified and appropriate actions are taken. And you should apply the human factors principles even there as well. And we need to improve that safety culture as well by creating that shared responsibility, because ultimately the patient care is going to be influenced not just by the clinician who is monitoring and managing the patient, but also by all the decisions that are taken in the laboratory as well. Now, one thing I would like to signpost is an upcoming work from SHOT, and we want to work with all our transfusion colleagues and professional organizations involved with transfusion towards improving and working together to actually improve the IT systems. So this is the script work that we are actually going to embark on very soon. And this is the SHOT UK collaborative reviewing and reforming IT processes in transfusion. There will be several activities where we're engaging with all the relevant stakeholders. We would also be sending a survey to all of the reporters to actually understand what are the IT systems they use, what are the barriers, what are the challenges that they have, as well as we would also include the IT providers and therefore help identify the gaps and barriers, bringing everybody together and providing a platform and running virtual workshops, so that what we are trying to do is understand the systems, plug the gaps better, and build more robust systems. And please watch this space. There'll be more information coming up about this. Okay, so we have talked about how the policies, the systems, the resources, and the training, and how we work. It's also important to identify that staff should always be aware of the safety critical steps. Yes, it's always right that every step is important in this transfusion vein to vein. We need to aim to get it right first time, every time. But equally, when we look back at what are the weak points along the processes, like for example, in the laboratory, we see that the component labeling availability errors are the maximum here. So we know that that is actually the critical step. And therefore, this time, one of the recommendations was having that pause point there before the blood component is issued from the laboratory. Is this all appropriate? Is this the right component that needs to be issued? Is this actually in the right state to be issued? So I think having that pause to actually understand if everything is done, and I think it helps us if everybody involved in the transfusion process is actually vigilant, then, and you are not also making assumption that no mistake has happened in the preceding step, that would be helping improve patient safety. Similarly, that is the reason that administration checklist has been a key recommendation for several years. And we've also had the chief medical officer's recommendation that it has to be a key component for any transfusion. That is because we have seen majority of these errors could be actually picked up at that administration step. So even though errors may have actually happened, like following that Swiss cheese pattern, if you're able to still be vigilant and pick it up before actual patient harm, and then reflect and then address the gaps in the system, that would actually help in improving patient safety in the long run. So therefore, just reinforcing the message that we actually said, we should not be assuming anything, verify at each of the steps, and especially the patient identification, because correct patient identification at all the different steps is very much essential to ensure the right component goes to the right patient at the right time. Along the same theme about the safety, it's also important that the culture prevalent in an organization has a key role to actually play to ensure that the right systems are in place. And this is actually from the Nimrod review. This is from the aircraft industry, and where they say that there are 6 key elements to the safety culture in any organization. Like we have said, reporting is important, and that actually allows us to learn and avoid somebody else from making the same mistake or an error. We need to have that just culture. That should also be a learning culture. That are we learning? It's not just reporting one way, but are we actually then making sense, and what can we embed to actually change our practice? But we should also be flexible. So like that adaptability, understanding that, and actually be amenable to change what is the standardized practice depending on what we are learning. And we should be able to have that questioning culture. It is not just accepting what the norm is. And equally, we should be able to challenge each other as well, to be able to actually, or question each other to actually say, can you provide the rationale as to why this is the case? And I think in such a culture where there is open collaboration, coordination, then safety naturally would be actually following. So this year, as you would have seen in the report, what we are saying is that we need to have a synergy of the 2 systems, the safety 1 as well as the safety 2. And we need both approaches for the patient safety. So what do we mean is actually, while safety 1 goes on the premise that as few things as possible go wrong, safety 2 is a different aspect. It looks at safety, but it looks from a different aspect. And there, the starting point is actually that as many things as possible go right. And what we are saying is what Alison had already alluded to. What are the day-to-day deviations? And if anything is happening, can we learn from these? And so every experience matters, and learning from everything, having a debrief after this, and that actually enriches even the culture, and we learn from each other as well. So therefore, one of the key recommendations also has been that we need to, in order to truly improve the patient safety, not just learning from when things go wrong, it is also important to learn from when things are going right, which is in majority of the circumstances. So it is making every experience matter. Are we learning from each of these? What can we do to actually, improve this further? So this year, you would have also seen that in the SHOT report, we've embarked on this incorporating the learning from excellence, and we have introduced the chapter of SHOT ACE, which is SHOT Acknowledging Clinical Excellence in Transfusion. Watch this space. We would be actually progressing this a bit more in the next year so that transfusion teams would be able to report the excellence, from each of the trusts and the hospitals and the NHS to us, and we would be able to share the lessons learned and what was actually excellent about that report. So this is actually going to be a more holistic way of looking at safety and a more proactive way of looking at safety. And lastly, we also mentioned about how leadership is actually important. So this was in 2018 report, we had actually introduced this model to actually say lead to patient to transfusion safety and patient safety, whereas it is actually saying we've covered all the education, the attitudes and culture and people and processes, but what we're saying is leadership matters. We need a strong leadership, empathetic leadership, authentic leadership, and a supportive leadership. And as Alison has also alluded, it is actually the leadership that is provided by the managers and the leaders and the team is also vital in promoting the right culture. So what have we actually then, finally to summarize what we are saying is that to move forward, it has to be a multi-pronged approach, incorporating the human factors principles in every aspect of the patient care. So we need to ensure that we have the right building blocks. So we need to have the right staffing, the good skills and the experience mix. We need to build user-centered processes which are easy to follow. SOPs should also be easy to follow and more difficult to deviate. We need to be able to redesign our education training, and we need to be making it engaging, immersive, interprofessional training, and add the why to the what and how that we actually train. We need to be investigating incidents using the human factors principles. We need to learn from near misses, which are valuable learning opportunities. And we also need to take a step back with all these recurring events, such as the wrong blood and tube, and look at the process end to end and apply systems thinking principles with it. And we also need to have that growth mindset. We need to have the just and learning safety culture embedded. And we need to also ensure that the staff are engaged. The more engaged they are, better is the patient safety. They need to feel safe at the workplace, and ensuring psychological safety is also vital. And we always need to be actually reviewing, pausing, learning, and sharing the lessons learned. And this is what we are doing here. So lastly, I would like to acknowledge this is, although it's only a handful of us who are presenting here, this work is not possible and every one of you play a role in this. So thanks to all of you, our vigilant reporters and hospital staff who share their incident reports, to our UK Forum for Funding, to MHRA with whom we closely collaborate and work, and our wider SHOT steering group, as well as the working expert group. And I would also end by signposting another virtual meeting that is coming up. This is the Advances in Transfusion Medicine Symposium. This is on Thursday, the 26th, and the details are there on the Royal College of Pathologists website. This is a virtual meeting, and watch out for a presentation from SHOT, which would be about what are the achievements as well as the challenges. And just to remind everybody, this is the National Pathology Week, and we were having this webinar as part of the series of activities that SHOT team have been doing for the National Pathology Week. And we should all celebrate that indeed, yes, pathology and every one of us in it are at the center of the healthcare. So thank you. And we'll now open it up for the discussions.
Lovely. Thank you so much, everybody. I think that was a really fascinating presentation, and hopefully it seems to have been very well received. Just before we dive into the questions, we've had a couple of questions about recording, so just to let you know that this session is being recorded and it will be available on the website. We are doing our best with collating the Q&As. We'll get those up as soon as we possibly can. So our most popular question by far today has been about human factors resources, and thank you for those of you who have joined in. So they've listed a couple of resources that people have found useful, such as terima.co.uk and a course at the University of East Anglia. So those are two that people have shared that found useful. Alison, what other resources have you found useful?
I mentioned it briefly in I think, or maybe I didn't, the Clinical Human Factors Group, which has an online presence. There are good videos on there. They occasionally do one-day seminars and things like that. And because it's clinically based, it's obviously very much more useful to us. There is, of course, also the Chartered Institute of Ergonomics and Human Factors. That was the one that was mentioned earlier, which and they cover all of the human factors, so obviously aviation, nuclear, everything else as well. And there's plenty of books and things out there. I mentioned Stephen Shorrock's work. He writes a constant blog, so he's not just working on those things at the moment. His is a very informative website. And there's lots of videos out there. We have a nice little video on the human factors investigation tool. And I think we signposted a second one this year, but there are others out there. So I think there's quite a few resources there. And shops, of course.
Lovely. Thank you so much, Alison. So hopefully we've got a few things there. And we
just to elaborate on that as well, around videos, we are in the process of developing one as well, specific to human factors and transfusions. So keep your eyes out for that. Hopefully the beginning of next year, that should be available.
Perfect. Thank you, Emma. Yeah, and we might even, we'll hopefully collate some of those resources from you, Alison, and we might put some links underneath the video when we post it. So that should seem like a good idea. A couple of related questions that I think I might pop together now, if that's okay. So about how do we convince senior management to understand the importance of human factors? And related to that, how do we persuade those that hold the purse strings to invest in IT systems and other systems that help improve human factors? So has anybody got a burning desire to answer that one?
I can kick off, and then I think what we are doing is working. So what we at SHOT are actually trying to do is actually then send a communication out to actually signpost the importance, as is evident from our SHOT report, and we are trying to actually communicate with all the chief executives, the medical directors, as well as the nursing leads. Now this is actually a work in progress. There is our recommendation out there as well, and increasingly not just in the transfusion community, in the wider, in all aspects of the patient safety, this is being increasingly recognized that unless we put in the right resources, train our staff, and understand the human factors principles, patient safety cannot always, we can't always deliver the safe patient care. So I think it is a bit of all of us are in it. We are all part of the system, and we all have a role to play. It is not just anyone's responsibility, but all of us together, working together can build that momentum and that wave to actually, each of us is a change agent. And I think we have to actually convince to actually say this can work, and all of us have that capacity to actually make a difference, but we need all of these things to be placed. And I think it is this one responsibility to actually signpost whatever resources, and we are here to actually help and support in whatever way possible. So please do contact us. Alison, I don't know if you had anything to add to that.
Well, I think I'd like to add what SHOT does, because there are recommendations. I mean, going back a few years, there was the recommendation that end-to-end IT should be introduced. There are recommendations about the human factors training, and there's all the data in there also about the sorts of things that can go wrong and the catastrophic outcomes for patients. So I think those are the things that people can highlight when they're trying to make a case for better resourcing. I think there's also, I do believe the MHRA investigation or audits do look at staffing, and so that's another one. And I think Emma mentioned earlier about the templates for the correct staff mix in laboratories and on wards and such like.
Mm-hmm. And serial UKTLC surveys have also shown the same thing, that there are actually gaps in the staffing, which are actually, and the culture issues. So I think, all of us are actually then, talking this one to build up that momentum, and there are plenty of resources available. Sorry, Emma.
Yeah, I was just going to say in very practical terms relating to finances towards IT for vein to vein. It is a nice recommendation as well. And if you go on the website, I've not been on for a while, but there are kind of examples of costings and which can be used towards business cases, and sets it out actually in very practical terms. So even though the initial outlay seems huge, it compares that to kind of, saving on staffing time. So for example, if you've got 2-person checking at the bedside, so that's quite a good resource to have a look at as well.
Lovely, thank you for that. Some good resources there. I'm trying to think, thank you everybody, we've got lots and lots of questions here. I think one that I can maybe say together is about design issues. So I've had a couple around that, around Have we got any data or do anything about design of products, design of giving sets, design of things? Have we got any data to do with that, or any signposts to resource point towards for the importance of enacting change when they found that a design issue may be impacting safety?
I think we have not done any active this one about the design, but definitely wherever errors are highlighted. So for example, we've also seen where, from a blood bag where there are mixing up the blood groups, or if there are actually errors in interpretation from a blood gas as well. So I think it is not something that we have actively employed with the design of the products, because we are not involved in that design, but I think it is signposting wherever errors are actually reported to actually highlight the principles. I don't know, Alison, whether you have done any work with this?
Not specifically, although obviously it's something I'm aware of. It occurs to me that SHOT was involved a couple of years ago in the change to the irradiation label on blood units. I'm assuming that's gone live since I've left the world of transfusion. But that's a good example of design problems. So those were highlighted at the procurement stage, and with SHOT's input, NHSBT and others were able to negotiate to get a better design of that label.
Lovely, thank you. Slightly opposite track to this, there's a couple of questions about human factors are talking about systems and things, but actually about the people involved and about emotional impact. And I think that's really pertinent at the moment. So if anybody anything to say about centering the person and the external factors on people in system design and capacity and stretch and things like that within systems?
Yeah, sorry, Alison, you were about to start.
Well, I was just going to say, I think it is a problem, and there's a bit of a tendency throughout the NHS to look only at the human aspects of human factors. That was mentioned by Emma earlier. There's also a tendency to use the word resilience slightly incorrectly. So they talk a lot about making doctors more resilient, about making nurses more resilient, which puts the emphasis back on the people again. Whereas the work that I was doing that I highlighted earlier is about making the system have more capacity to be resilient rather than relying on the individuals.
Yeah, what I would like to add is, yes, I think the slide that Emma had shown about the impact on the staff, that is very, very real. And I think these are additional victims as well. So I think what we need to see is, I think we, like we all know, we don't come to work thinking that, okay, I'm, making an error today, and it is actually the result of several circumstances. So I think what we need to remember is, to be able to support the staff, but also investigate it in a just culture way and embed the learning from that, and also improve the confidence, because I think it is also a reflection point and discussion with the manager to be able to actually then say, what can be actually done better. And otherwise, what we don't want is actually the person being paralyzed so that they're not coming back to do that work again later. So I think it is learning, embedding the learning, supporting the staff, but equally actually embedding the learning from it so that they are able to do that activity better again later.
Yeah,
lovely.
Absolutely.
Sorry, Emma, were you going to?
No, I absolutely agree. It's doing it in a fair and just way, I think, isn't it? Taking into account all factors. Yeah.
Lovely. I think I'll just finish up with one more here around IT systems, and maybe a little bit of signposting again to the scripts work that we're hopefully starting out about the effectiveness of putting in barriers to stop people overriding alerts and without giving reasons. So I think that's something we're definitely going to be looking into. Have anybody got any experience or anything they'd like to share about forcing functions?
I think that Shriti's example was very good about IT systems that won't allow you to do ABO incompatible. I think the one that's often left out in transfusion is the plasma components. So there should be forcing functions that will not allow you to issue a group O plasma in an emergency situation or to a patient without a blood group, etc. And it seems that they've concentrated very hard on the ABO red cells and forgotten about the opposite effects of the plasma.
And Vicky, I think, can I pick on one of the other questions that has been asked as well? They've said about is SHOT involved in the new NHS way of investigation of the incidents, the PSI-RF? Now, that is actually the Patient Safety Incident Response Framework. Now, what I would like to clarify is, I think the new NHS patient safety strategy that actually came out, that was the middle of last year, we have been involved as one of the, for consultation, and then we fed back from the SHOT point of view. What I would like to clarify is SHOT, as the Hemovigilance Organization of UK, we are not directly involved in any of the incident investigation. However, what we do, it's almost having a finger on the pulse, and we collect the information on how incidents or have been investigated. So I think whatever we are actually mentioning now is, okay, what are our reports telling us, and where can we actually improve? What is being done well, and what can we do better? So I think we are not directly involved in the patient investigation, but we are actually aware of these different frameworks. And what we are saying is, these are the messages that are actually coming through when our reporters are actually submitting how incidents are being investigated. And I think what our principle would be is what exactly the framework would be saying is, incorporate, we need to have a proactive approach, to investigate the near misses. We need to be having that human factors principles, and many of these may already be in use. Like, for example, the contributory framework, the Yorkshire framework that is there, and you may have different human factors principles, and many may already be using this. And I think it is these principles, applying that and making sure that you're learning the lessons learned. So, if it is learned in one department within an organization, how are we sharing it? It is breaking that echo chamber effect to actually break across and actually say, this can occur even in the other situations. And therefore, how do we actually promote that learning? I think that is where we would come from. Thank you.
Lovely. I think we'll have to collate the rest of the questions because we're running a bit short on time now, but I'm just going to pass over to Emma, who's got something, got a little bit of follow-up.
Yeah, okay, so we've tended to finish these webinars with a live poll, so you should see that appearing on your screens hopefully anytime now. There we go. So if we could just ask you to score to which extent you found the session useful, with 1 being not very and 5 being very useful, and this just really helps us to inform and evaluate our sessions. Also the country that you're viewing from, and how many are you viewing. And after some feedback from one of our webinars, what we were told is that occasionally different groups of multiple staff will be socially distanced viewing from one device in a room. So that will just give us an indication of our attendance today and just give us some very useful analytics. And again, with staff group, we were aware there might be different staff groups viewing together. So if you could just give us an indication of that, that would be very much appreciated. So this just about brings the webinar to a close. Again, thank you for taking the time out today to actually join us and attend. We hope you found it interesting and informative, and it's offered some sort of opportunity for shared learning. And we find as these webinars are going on that we're getting more and more questions and interaction, which is great. And we will endeavour to answer those questions retrospectively once we've had chance to do that. The recording has been mentioned. That will be available on the website within the next week or two. So you can view that again. Please pass it on to any colleagues who weren't able to attend today and who you think that might be useful for. A reminder that our virtual SHOT door is always open. We're here to be contacted about any reporting queries or just in general, and we'd love to hear some feedback and ideas for future webinars. That's always useful to us. Thanks again to the panelists, and just a special thank you to Michelle Darcy, who's kind of our silent partner in all this really. And Michelle really helps us with the technical side of things and is absolutely instrumental in that. So a big thanks to Michelle as well. Okay, thank you very much. See you next time.
Thank you.